Hello, this is Professor Tiam with the last lecture of the semester, Unit 8, Module 6, Interferences with Integumentary Needs. Here are your subcompetencies for this module. We'll be reviewing the following diagnoses, including the A and P of the skin, and therapeutic management, lab tests, medications, and other interventions used to treat and diagnose these problems, as well as strategies to prevent them and the nursing process. The reading for this module is from your Ricky textbook, Chapter 45, as well as pages 1204 to 1206. Pediatric skin is different from adult skin, and these differences affect how nurses assess and care for children. First, pediatric skin is thinner and more loosely attached to the dermis, and because of this, friction can easily cause blistering or the breakdown of the skin. Nurses have to handle infant skin gently and cautiously, especially with the use of adhesives or tape. Another thing is that pediatric skin is more permeable, which allows topical medications to be absorbed more easily, but also it increases the risk for systemic effects since the pediatric skin is more permeable. So nurses have to be careful about the amount and type of the topical medications being used on pediatric patients. Children can also lose heat more easily through their thin epidermis. Their temperature regulation system is still immature, especially in the infant stage. So in particular, they can become cold quickly. Maintaining a warm environment is important. Sebum production is low during childhood, but increases during the adolescent years because of hormonal fluctuations. This increase in oil production is why acne commonly develops during the teenage years. And another point is that children with darker skin may have stronger skin reactions, and they're more prone to hyperpigmentation and keloid formation after skin injuries. So changes in skin color after healing may be temporary or permanent. Because pediatric skin is thinner, more fragile, and absorbs substances more easily, nurses have to pay attention to skin protection, such as SPF, medication use, and temperature regulation, especially when caring for this vulnerable population. Nurses assess pediatric skin disorders by first beginning with a thorough health history. So nurses will ask about symptoms such as itching, scaling, any cosmetic concerns, allergies, and family history of atopy, which is a genetic tendency to develop allergic diseases, including allergic rhinitis or asthma, because there is a correlation with asthma and eczema, because many of the pediatric skin conditions are related to allergic disease. So we want to identify the triggers, if there's any environmental exposures, foods, or irritants that cause the skin disorder. During the physical examination, nurses will assess the skin lesion, including the distribution, for example, if it's localized or generalized, if it's symmetrical, or it's in a sun-exposed area. Also the shape, such as target, it looks like a bullseye here, linear shape or annular, circular shape. Also the type of lesion, it could be many different types, including nodule, pustule, papule, and I'll have an image of that in the next slide. Other diagnostic test that the nurse will expect to gather is a KOH prep. This one's used to identify fungal infections by examining skin scrapings under the microscope. CBC or complete blood count can help identify any infection or inflammation. ESR stands for erythrocyte sedimentation rate, and it's a marker of inflammation that's not specific. Immunoglobulin E levels, also called IgE levels, are often elevated in children with certain atopic dermatitis or allergic conditions. This is a type of antibody that's produced by the immune system, and it's responsible for allergic reactions by triggering the release of histamine once it identifies that allergen. Here are several different types of lesions that you may find on the skin. This is from your fundamentals textbook and should be just a refresher, but I'm just going to quickly mention them. So the macule is non-palpable, less than 1 centimeter, and some examples are like a birthmark or a freckle. A papule is less than 1 centimeter, is common in keratosis, a seborrheic keratosis. It's elevated and raised but superficial. There's the vesicle, which is less than 1 centimeter, such as a blister in this picture shows you examples of that. Cysts are palpable, and here's an example. There's a keratogenous cyst that's less than 2 centimeters. It's considered a cyst if it's less than 2 centimeters. It's fluid filled as well, encapsulated. If there's no fluid and it's hard, it's called a nodule, which you see down below. An elevated, solid, and firm nodule, for example, a wart or lipoma, is considered a nodule. And then we have your pustules, which are palpable and elevated, filled with pus, for example, acne or impetigo, as seen in this picture, are examples of pustules. For pediatric sun protection, sunscreen should be used for all children, and current recommendations suggest using a fragrance-free sunscreen with a 30 or higher SPF. Pediatric sun protection includes the use of sunscreen, which should be used for all children older than 6 months. For those under 6 months, it's not recommended by the American Academy of Pediatrics or the FDA to use sunscreen. However, shading in clothing and avoiding the sun is the best recommendation for younger infants. It's recommended to use PABA-free or PABA-free sunscreen, which is a chemical called para-aminobenzoic acid. It's helpful to prevent UVB, ultraviolet B radiation because it absorbs it, but it is also frequently associated with skin irritation and contact dermatitis, which is why it's not recommended for children. So any PABA-free sunscreen is recommended with an SPF of 30 or higher, especially for adolescents or children spending time outdoors at the beach or other high exposure environments. Sunscreen should be applied about 30 minutes before sun exposure and reapplied every 2 hours, especially when swimming or sweating. They're going to need that reapplication. It's recommended to avoid direct sun exposure between 10 a.m. and 3 p.m. Of course, if the children are at a summer camp, a sports camp, or a beach vacation, that might not be very easy to do. So the recommendation is just to use sunscreen during these times. If possible, avoid these long periods outdoors, but of course, we have to make sure that application and reapplication of sunscreen with an SPF of 30 or higher is used. Children with lighter skin or certain medications may be more susceptible to sunburn. Fungal infections of the skin in children are called tinea infections, and these infections are caused by fungi which are highly contagious through direct skin contact or by sharing items like hats, combs, towels, or brushes. There's two common ones that we see in pediatrics. The first one is tinea capitis on the left, and on the right you see tinea corporis, which is also known as ringworm. Tinea capitis affects the scalp and typically presents patches of scaling and hair loss. Treatment is antifungal medication that's oral and systemic, usually oral griseofulvin for 4 to 6 weeks is used. Tinea corporis, again ringworm, is affecting the skin of the body, such as the face. The book does mention it's more in the arms and legs, but ringworm can also be seen throughout the body on the chest as well as the back. It's an annular or circular ring-shaped lesion with a raised scaly border, and the inside is central clearing. So you see that kind of ring around that clear circular area in the middle. Management of this focuses on good hygiene and also antifungal medications. However, these are more topical antifungal creams that are used for at least 4 weeks. It's contagious. Children with ringworm, however, can return to school or daycare once treatment has started. Contact dermatitis is an acute hypersensitivity reaction that occurs when the skin comes into contact with an allergen. It's a cell-mediated immune response, so the reaction develops after the immune system has been exposed to the substance. Common causes are poison ivy, poison oak, poison sumac, nickel in jewelry, chemicals also that can be found in cosmetics or hygiene products, or clothing is another common cause. So the rash itself is very intensely pruritic or itchy. It may appear as red papules or vesicles, so erythematous papules or vesicles. When caused by poison ivy, the rash usually appears in a linear pattern on the exposed surfaces of the skin. The rash can last about 2 to 4 weeks, and a common belief is that scratching can spread the rash, but it's the allergen that has already triggered a reaction in the exposed areas only. Scratching it can increase irritation to nearby skin or the risk of secondary infection, but doesn't necessarily spread the rash any further. Treatment includes relieving the itch and the inflammation, so topical corticosteroids are commonly used. If it's very severe, it may require PO, systemic steroids. Over-the-counter calamine lotion and oral antihistamines can also reduce this itching. So that's your Benadryl or your Zyrtec, hydroxyzine. Those can help reduce itching as well. So prevention is key here. If the poison ivy exposure occurs, washing the skin vigorously with soap and water for about 10 minutes can help reduce the severity of the reaction. Scabies is a contagious skin infestation caused by a mite called Sarcoptes scabiei. The mite burrows under the skin and lays eggs. Transmission usually occurs through skin-to-skin contact with an infected person. The most common symptom is intense itching, especially at night. Patients typically develop an erythematous papular rash with excoriations from the scratching. Common sites are the hands, the feet, the wrists, and the skin folds. They like to burrow under those skin folds. So any crevices of the body is where they usually like to burrow their body and lay their eggs. So in infants and young children, lesions could also appear on palms, soles, fingers, and scalps. They may develop vesicles or pustules. Diagnosis is really based on the symptoms of severe nighttime itching or nocturnal itching and similar symptoms in close contacts with the patient. Skin scrapings can be examined under a microscope, and this will reveal the mites. Treatment includes a topical scabicide called permethrin 5%. It's a cream that's applied from the neck to the soles, and this is applied very thoroughly all over the skin from the neck down to the feet. It's put on after bathing overnight and then washed off in the morning. Infants and young children must also have their head, the areas of their face that's exposed, and again, the neck especially has to be treated. It's often repeated in 1 to 2 weeks. Itching may continue for several weeks even after treatment. For infants under 2 months, permethrin isn't approved, so this is more for 2 months and older. The nursing care of scabies focuses on infection control. Patients should be on contact precautions. All household members have to be treated at the same time. And bedding, clothing that were used within the past 3 to 4 days should be washed in hot water and dried on high heat. The living areas have to be thoroughly cleaned and vacuumed also. Here's an example of scabies on a pediatric patient. They really like to stay in the skin folds and crevices of the body. So the armpit here, the hands, the feet. On young children, scabies like to burrow in the palms and the soles of the feet as well as fingers. Pediculosis capitis, also known as head lice. It's caused by a parasite called Pediculus humanus capitis. Transmission usually occurs through direct head-to-head contact, which is why it spreads very easily among school-age children. The most common symptom is intense itching, pruritus, due to irritation from the bites of the lice. When assessing a child, the nurse should look carefully behind the ears and at the nape of the neck, as well as the entire scalp where lice and nits are found. Diagnosis is made by the visual identification of lice or nits attached to the hair shaft. Treatment includes an over-the-counter pediculicide. This is permethrin, again, same thing as what scabies is treated with. Scabies is permethrin 5%, along with a manual removal of nits using a fine-tooth comb. Nurses should educate families to check the hair every few days, to treat all close contacts if symptomatic, and to wash recently used clothing and bedding in hot water. So kind of similar to scabies treatment. It's also important to reassure families that head lice is not a sign of poor hygiene or low socioeconomic class. This is a very common misconception. It can happen to anyone. So again, treatment is permethrin, and typically that is a shampoo. So that's not a cream as scabies treatment was. Impetigo is a highly contagious bacterial skin infection that's commonly seen in children. It's typically caused by a bacteria called Staphylococcus aureus. These organisms normally live on the skin, but infection occurs when bacteria enter through minor skin trauma, such as a scratch or even insect bites or dermatitis. It first begins as small papules that progress to bigger vesicles and pustules. When these lesions erupt, they form a classic honey-colored crust that you can see in this picture here. That's very characteristic of impetigo. The lesions may range from a few millimeters to several centimeters. During assessment, the nurse should look for that typical honey-crusted colored lesion, most commonly found around the mouth or nose. So the lesions are painless, but it can cause itching. The nurse should also assess for fever or signs that the infection is spreading. Treatment depends on how severe the infection is. Mild cases are typically treated with topical antibiotics, such as mupirocin, and this is applied 3 to 4 times daily for about 5 to 7 days. If the child has numerous lesions or a more extensive disease throughout the body, a larger patch of it perhaps, that won't go away with the topical antibiotics. PO oral antibiotics can be used and prescribed by the provider, such as a first generation cephalosporin, for example. So nursing care focuses on skin cleansing, so strict hand hygiene. Infection control is very important here. Education for parents. This is a very contagious disorder, so infection control is a priority here. Crusts should be softened with cool compress and gently cleansed and removed with the compress. Soap and water can be used to wash it. However, parents should be instructed that sharing towels should be avoided. This is very contagious again, so no towels, no washcloths shared to help prevent the spread of the infection to others. Although it's very contagious, children can go to school as long as there is no active drainage, or they've started antibiotics for about 24 hours. So they should not be excluded from school unless the lesions are contagious, and you could see that when it's moist and wet and not, you know, crusted over. Again, antibiotics should be started as well if they're going to return to school. Atopic dermatitis, commonly called eczema, is a chronic inflammatory skin condition that causes intense itching and dry, inflamed skin. Relapsing and remitting is common. It tends to come and go over time. It's commonly associated with other allergic conditions such as asthma, allergic rhinitis, or food allergies. Children often experience severe itching, dry, scaly skin that's red in color, and sleep disturbances due to scratching. The conditions that worsen atopic dermatitis include excessive heat or swelling, dry or excessive humid conditions. Stress and skin irritants as well can cause it. So the location of the rash changes with age. In infants, it's commonly seen around the face, the scalp, the arms, or the legs, whereas in older children, flexor areas such as elbows and knees often present where the eczema is located. Some treatments for eczema include frequent skin hydration and moisturizers. As we said, dry environments may exacerbate or trigger eczema, so a humidifier may be needed for the room if eczema is flaring up. Topical corticosteroids are also used. PO immune modulators, antihistamines can help with the itching, as well as provide as a sedative for sleep if itching is keeping the child awake at night. If there's secondary infections and it's gotten very severe and we're worried about infection, antibiotics may be used as well. So nursing care is focused heavily on skin care and hydration. So if the child's able to take 2 warm baths or showers a day, that would be very good. We're going to avoid hot baths, but warm water is good, as well as fragrance-free products such as soaps and lotions. Moisturize frequently. Keep the nails short, especially if the child is scratching a lot. And we want to avoid any triggers. Perhaps use cotton clothing and bedding that might be more comfortable for the child. For the adolescent age, we know that body image is a big part of this age group. So the nurse could reassure them that scarring is unlikely to happen if the treatment plan is followed, and that usually improves the adherence to the treatment plan. Here is an example of atopic dermatitis on the face of a child. Acne vulgaris is a very common skin disorder affecting about 85% of adolescents. It involves the pilosebaceous unit, which includes the hair follicle and sebaceous glands. During puberty, androgens stimulate the sebaceous glands to produce more sebum. At the same time, abnormal shedding of skin cells can block the follicle, creating a keratin plug. This environment allows the bacteria called Cutibacterium acnes to grow, which leads to inflammation and the development of acne lesions, hence the name acne. Clinically, acne appears on the face. It could appear in the chest and back where sebaceous glands are most active. So nurses should recognize the difference between non-inflammatory lesions such as blackheads and whiteheads versus inflammatory lesions such as papules, pustules, nodules, or cysts, because they can become a lot worse. Treatment focuses on reducing bacteria, decreasing the sebum production, and preventing inflammation. Adolescents are often prescribed with medications like benzoyl peroxide, which is topical, or retinoids, but benzoyl peroxide is the treatment of choice. There's also salicylic acid that's commonly available over the counter as well. Topical or oral antibiotics may be needed if inflammation results from severe acne. And if nothing else works and trials were used, isotretinoin is another treatment that they may try. However, this is very harmful for pregnant women, so an HCG test may be needed before prescribing isotretinoin in the adolescent population. Even if they're younger, they will still require ruling out pregnancy first. An important nursing role is education, especially reminding the patient not to squeeze or pick the lesions because that can lead to scarring. So use gentle cleansing twice daily and only use non-comedogenic skin products. Sunscreen is also very important, especially if they're using topical medication for acne. Improvement may not happen until about 4 to 6 weeks, so patience is required here. And we know that acne can significantly affect body image during adolescence, so they may need emotional support and reassurance that the medication will work as long as they try, and they may have to trial various things in order to have an effective treatment plan. A vector-borne illness is an illness that is transmitted to humans through a living organism called a vector, and Lyme disease, unfortunately, is the most common type in the United States. So this is caused by a spirochete, which is a long, thin spiral shape that moves in a corkscrew. So that's why the bacterium is called a spirochete. It's Borrelia burgdorferi from the transmission through a bite of a tick. It usually requires the tick to remain attached for about 36 to 48 hours for the transmission to occur. So early removal is absolutely important for prevention of Lyme disease. The disease progresses in 3 stages. So the early localized stage is characterized by that classic bullseye rash that you could see up on the top right-hand screen. That's also called erythema migrans, and that appears at the site of the tick bite, usually about 1 to 2 weeks after. If untreated, the infection will progress, and children may develop systemic fevers like fever, fatigue, headache, myalgia, which is muscle pain, or arthralgia, joint pain. Neurologic signs can also manifest, such as facial nerve palsy, and that's the cranial nerve 7 that's affected. In the later stages of Lyme disease, patients may develop recurrent arthritis, especially of the large joints such as the knees. I've seen Lyme disease manifest in other ways. I've seen patients have nausea and vomiting that persists for a very long time, as well as extreme migraines that take a long time to fully treat. I've also seen it manifest as paralysis in one patient, but that was very rare. So it does manifest in different ways amongst patients. So the diagnosis is usually based on these symptoms mentioned here. Exposure, for example, did they go out in the woods? Were they going on a hike? Also, laboratory testing is important, and the CDC recommends a 2-step test that includes an enzyme immunoassay and a Western blot confirmation, but you don't need to know those lab tests. So treatment typically involves antibiotics such as doxycycline or amoxicillin, and when started early, the prognosis is pretty good, so early treatment is very important. An important nursing role is education and, of course, prevention, so teaching parents to check for full body inspections, especially after outdoor activities, wearing bug spray and wearing long sleeve protective clothing, especially in the tick infested areas, are important. The nurse should remove ticks promptly using a fine tip tweezer without twisting or jerking the tick. So we're gonna go straight to the base at the head where the bite is. So they're pulling that in a straight up motion so that head is removed. There should be no twisting or jerking or finagling of any kind. Sometimes the nurse may keep this, for example, in a school or camp setting, if parents want to take it and for whatever reason they may want to give it to their provider just to confirm if this bacterium is present or not in that tick. And finally, let's talk about cellulitis, which is a bacterial infection of the skin and underlying tissue. It most commonly occurs when bacteria enters the skin through a break, such as a cut or an insect bite or abrasion. The 2 most common organisms that cause cellulitis are Staphylococcus aureus and also group A beta hemolytic streptococcus. So bacteria causes this infection. Clinically, cellulitis presents with redness, warmth, swelling, and tenderness at the site of the infection. It can occur anywhere on the body, but it often affects the extremities. Children may also develop cellulitis around the eye, and this is known as periorbital cellulitis. So during assessment, nurses should examine the skin carefully for worsening redness, swelling, discharge, or purulent drainage. Palpation for regional lymphadenopathy is also important. In the case of periorbital cellulitis, we can ask about the the recent history of sinus infection, because it's known that sinusitis is a common source of periorbital cellulitis. Nurses should recognize signs that the infection has progressed to orbital cellulitis. So this could include redness of the conjunctiva, changes in vision, pain when moving the eye muscle weakness. These could be emergent findings, so this is very important to recognize when it gets more severe. Mild cases of cellulitis are typically treated with oral antibiotics. More severe infections or orbital cellulitis, as we discussed, may require IV antibiotics. An important nursing responsibility is education again, so we teach the patient and parents to finish the full course of antibiotics, even if the child appears to be symptom-free, and monitoring worsening symptoms and ensuring there's no medication allergies are checked before administering these antibiotics.